Good afternoon, dear colleagues. It's my pleasure to present you the new guidelines of the European Society of Cardiology on endocarditis. I have no disclosures. These new guidelines updated the previous issue, which was published in 2015. These guidelines were presented last Friday at the European Society of Cardiology Congress in Amsterdam. Of course, it's not possible to summarize all the guidelines in 10 minutes. However, I will try to address which seems the most important point. First, let's begin with the prophylaxis of endocarditis. It is important because it concerns a large number of cardiologists, not only those specialized in the management of endocarditis. There are no major changes. Antibiotic prophylaxis remains recommended in high-risk patients for endocarditis, that is, patients with previous infective endocarditis, with prosthesis, and in certain cases of congenital heart disease. And this is recommended for dental care. The only difference is that now it's a class 1 indication, while it was only 2A in the last guidelines. This is due to new evidence that antibiotic prophylaxis is efficient in these patients. Regarding high-risk groups, these are always the same, and it has not been strengthened by recent epidemiological findings from large administrative database, which shows a considerable increase in the incidence of endocarditis in high-risk patients. If we see here, we can see at the right the incidence of endocarditis in the general population, which is between 30 and 50 per million inhabitants per year. And we see that in patients at intermediate risk of endocarditis, that is in particular patients with native valve disease, incidence is multiplied by more than 100. It's even higher in patients with valve prosthesis, and it is the highest in patients who have previously had endocarditis, in whom the recurrence rate is greater than 1% per year. Data which now strengthens the recommendation for antibiotic prophylaxis in high-risk patients come in particular from this large observational analysis coming from the Medicare database in the US, which analyzed in more than 3,000 patients hospitalized for endocarditis the association with previous dental care and with previous antibiotic prophylaxis according to the risk categories for endocarditis. And clearly, oral surgery, tooth extraction, endodontic care was associated with a much higher incidence of endocarditis when there was no antibiotic prophylaxis in blue, as compared with patients who underwent antibiotic prophylaxis in red. In patients at moderate or low risk, the difference was not significant, and this also supports the absence of recommendation for antibiotic prophylaxis in this patient. So no major change, but clearly strengthened recommendation for antibiotic prophylaxis in high-risk patients. This slide did not change as compared with the previous issue, but is probably the most important for prevention. Antibiotic prophylaxis is important in selected patients, but it is even more important to maintain good hygiene measures, which should be applied ideally in the general population, but of which all, of course, should be reinforced in patients at risk of endocarditis. These guidelines also emphasize the role of endocarditis team. Endocarditis is not a frequent disease, and therefore it is important that any referring center has the possibility to communicate easily with an endocarditis team for improving patient management and leading to referral of patients when needed. Regarding microbiological identification, no major update. Blood culture, of course, should be performed before any antibiotic therapy. And if blood culture are negative, it is necessary to perform serology to search for intracellular microorganisms. Regarding echocardiography, this slide comes from the previous guidelines of 2015. There have been no change, and of course, TTE should be performed very soon when there is clinical suspicion of infective endocarditis. Transesophageal echocardiography will be most frequently performed by TTE is the first investigation to perform. This is due to the diagnostic performance of TTE and TOE, which is well known. Of course, transesophageal echo is more sensitive than transthoracic echo, but it has a high specificity. And if there are suspect images according to TTE, this is enough to be a major criteria. These guidelines emphasize the role of multimodality imaging besides echocardiography, in particular CT and nuclear imaging, which is now recommended in class 1 in symptomatic patients for whole body imaging, but even in class 2B in patients who do not have any symptoms suggestive of peripheral embolism. This was in particular supported by the recent TEP-VENDO study, which assessed the impact of systematic TEP imaging. Not surprisingly, cardiac uptake was less frequent in patients with native endocarditis, but it is known to be less sensitive than for prosthetic endocarditis. But TEP was useful in detecting non-cardiac uptake in almost half of the patients, the same for native or prosthetic endocarditis. And this leads to reclassify the diagnosis and, in certain cases, to modify therapeutic management. The diagnostic workup is detailed in different flowcharts. This one is for native endocarditis. We can see that multimodality imaging is a class 2A recommendation when endocarditis is not definite. The recommendation is even 2A for multimodal, is even class 1, sorry, for prosthetic endocarditis when the diagnosis remains doubtful after echocardiography. There is also room for multimodality imaging in endocarditis on pacemaker or defibrillators, but this is to be modulated according to whether this is for detect pocket infection, it's class 1, or lead infection, only class 2B. So clearly, strengthen part of multimodality imaging according to the presentation. Let's come to the treatment. Of course, antibiotic remains mandatory. It is well detailed for all microorganisms. The main innovation in this recommendation is the possibility to perform switch to oral antibiotic therapy after 10 days in selected patients. There are strict criteria for that, but this is a major advance for patient care, and this is the consequence of the randomized POET trial, which was published in recent years. This is now a class 2A recommendation with A level of evidence for switching to oral antibiotic therapy in selected patients. Before to conclude, these guidelines also emphasize the importance of post-discharge follow-up and patient education. And in particular, as previously seen, patients who had experienced endocarditis have a high recurrence rate, more than 1% per year, and therefore it is of utmost importance to check on a regular basis that they know and that they implement prophylaxis measures, that they have regular dental follow-up, in particular, because it is not always the case in current practice. This was shown in a recent observational studies that was performed in our department in 100 patients who had previously undergone endocarditis. The knowledge on preventive measurements was relatively good, but less than half of the patients applied really this prophylaxis measure in daily practice. So to conclude, these new guidelines integrate recent findings in different fields of endocarditis, in particular regarding prevention, diagnosis, and treatment. It is centered on patient care through a shared decision-making process. And I encourage you to read the whole documents, which will be highly useful for daily practice. Thank you for your attention.